Hello, I'm Christina. I will be doing my case study and evidence-based guidance presentation on COPD and upper respiratory viral infection. The patient I will be discussing today is John Doe. He's a 52-year-old male, Caucasian male, and he presents to the clinic with the chief complaint of cough and increased sputum production. History of present illness. Mr. JD endorses that his increased cough began 3 days ago, in addition to the clear to white sputum production, mild sore throat, and low grade fever of 37.8 degrees Celsius, which was his T max at home. He reports that his dyspnea is only slightly worse than his baseline dyspnea. And then the effect on his chronic illness, he reports using his rescue inhaler more frequently during this acute period the past 3 days, but he is still getting relief when using the rescue inhaler, and he's still able to perform his usual ADLs, activities of daily living. His past medical history, past surgical history. COPD was diagnosed 3 years ago when he was age 49. His baseline forced expiratory volume in 1 second was 62%. And he was hospitalized last year for an exacerbation from a bacterial pneumonia, which he was able to recover from. He has never been intubated. Additional past medical history is GERD, gastroesophageal reflux disease, which was diagnosed this year. He's been able to maintain his symptoms with lifestyle and diet modifications, as well as occasional famotidine use. Of note, he also had an endoscopy last year during the time of the GERD, which was found to just have like mild esophagitis with upper gastritis. And he was on a course of pantoprazole for that, but he's recovered from that, and his symptoms are a lot more mild and just controlled with famotidine use. GERD is actually a not totally infrequent comorbidity with COPD, which is something interesting to note. And then additionally, other past medical history is asthma, which he is able to maintain with Flonase daily use during allergy season. And then he also has his rescue albuterol inhaler as needed. Medications and allergies. He has no known allergies. Medications include a LABA and LAMA combo with salmeterol and tiotropium, which he uses daily for his COPD maintenance. He also has his rescue inhaler, the SABA albuterol inhaler, which he takes 2 puffs of Q4 as needed for exacerbation of the asthma, or, also which he's been using for exacerbation of his COPD symptoms during this acute illness. And then, like we previously stated, the famotidine 20 milligrams daily as needed for heartburn and GERD symptoms. Review of symptoms or systems according to Mr. JD. He reports a low-grade fever, like I said, Tmax of 37.8 Celsius. He denies confusion or altered mental status, which would indicate fever, something more systemic going on, something a little more sinister. He reports his dyspnea to be mild. He additionally endorses wheezing, a cough, clear to white sputum production. However, he's still able to perform his activities of daily living. He is using his rescue inhaler more frequently, but he is still getting relief from the symptoms when using the rescue inhaler. He also endorses associated sore throat. JD's social history includes smoking. He was a former smoker with a 30-pack year history, and he quit 5 years ago. He reports social alcohol drinking. He states he drinks about 2 beers once a week, and he endorses that he has never been a drug user. Diet and exercise. JD reports trying to follow a healthy diet, but he often eats fast food while at work. He drinks 3 cups of coffee per day, and he reports walking for about 30 minutes 3 times per week. He also works a desk job, so he has a pretty sedentary lifestyle. His family slash work. He's married with 2 children, and like I said, he works from home in cybersecurity. Health maintenance. In terms of health maintenance, JD is following the vaccine guidelines. He's up to date there, having received the flu vaccine for 2025, the shingles vaccine for 2023 when he turned age 50, and the Tdap vaccine in 2017, which is every 10 years, and then every 5 years if he's higher risk or if sustained some injury. Cancer screenings, he's also up to date with. He had a colonoscopy at age 50 in 2023, and then a lung cancer screening via low-dose CT in 2025. And then his routine exams, he's up to date with his dental exam, having had it in 2025, eye exam 2025, and then a dermatology exam in 2023. It's recommended that you are screened by a dermatologist for signs of skin cancer every 2 years. Eye exam, it's recommended from every 5 to 10 years, unless you have vision issues, then you should follow more frequently. And then dental exams are at least one time per year. Annual screenings with the primary care doctor, blood pressure checks at least yearly, cholesterol screening every 5 years, and then depression, anxiety screenings with the PHQ-9 and the GAD-7, respectively, which he had scored a 0 for both of those. And then following a heart healthy diet, and then cardiovascular exercise, especially since he has higher risk due to his family history of cardiovascular disease and his own cardiopulmonary diseases. JD's family history is significant for hypertension and congestive heart failure in his dad, and then breast cancer and diabetes in his mother, and then diabetes in his sister. His vital signs are blood pressure is 128/78, heart rate is 88, respiratory rate is 20, oxygen saturation is 94% on room air, and then his temperature is 37.8 degrees Celsius. And then I'm blocking this, but his weight is 192 pounds and he's 5'9", I believe. For his physical exam, patient is alert and oriented. He is appearing in no acute distress. He's speaking in clear and coherent speech. His throat was found to have mild erythema without edema or ulcerations or exudate on the tonsils. His lung sounds were found to have diffuse expiratory wheezes bilaterally, no crackles, and he does not appear to have increased work of breathing, and he's without accessory muscle use and no signs of respiratory distress. Today, his forced expiratory volume is 55%, predicted to be 55%, which is down from his baseline of 62%, which would be indicative of decreased lung capacity at this time. Additionally, like in the previous slide had said, his vital signs are pretty much stable. He's hemodynamically stable, and his respiratory status, according to the numbers, is appropriate. Key presentations of COPD. COPD patient would be found to have chronic progressive dyspnea, chronic cough with or without sputum, likely a history of smoking. Key findings would be prolonged expiratory phase, decreased breath sounds, wheezing, barrel chest, accessory muscle use, and pursed lip breathing. That's just a little bit about his history of COPD. And then diagnostic studies for COPD, which is already his known history, would be spirometry, showing post-bronchodilator FEV1 to FVC ratio less than 0.7, confirming airflow limitation. A chest X-ray or CT showing hyperindulation and flattened diaphragms. And then an ABG would be done if severe hypoxemia was was showing on exam, and possible hypercapnia. Now, what we suspect is going on with Mr. JD now is likely a viral infection. So diagnostics for a viral infection would be nasopharyngeal swab for a respiratory viral panel, or rapid antigen testing if indicated. We could do a chest x-ray if pneumonia is suspected, or if he had severe symptoms only. But more often than not, for a viral infection, clinical presentation is often sufficient for diagnosing. It's pretty much like a rule out, for the most part, very often a rule out diagnosis. But these, the RVP, or the rapid antigen testing, could be done, if we felt like it was necessary. Differential diagnoses for Mr. JD would be bacterial bronchitis, which is ICD-10 code J20.9. Key features of this would be for JD, he is at high risk for bacterial bronchitis due to his history of COPD and asthma. However, this would be more so a rule-in diagnosis, rule-out diagnosis. However, he does not have any purulent sputum, green, yellow sputum. His is white, clear. His temperature is less than 38 degrees Celsius, which makes it less likely a bacterial infection. We could officially rule this out with a culture if his sputum, became green or yellow, or we are unsure, or if his temperature got higher than 37.8 degrees Celsius. Another differential would be early pneumonia, ICD-10 code J18.9. Key features of this would be severe symptoms and a high fever. Severe symptoms would likely include increased respiratory rate, decreased SpO2, high fever, maybe a low blood pressure if it was becoming a sepsis situation. However, we can exclude the early pneumonia from being the diagnosis here, because Mr. JD has a low-grade fever, his SpO2 and respiratory rate are stable, and he does not have crackles when we listen to his lung sounds. He just has the wheezing. We could officially rule this out with a chest x-ray, which would show a consolidation or atelectasis in the lower lobes, or even higher, but I guess lower lobes if it's early pneumonia. And additionally, if it was like a strep pneumonia or Legionella, we could test that with the urine. However, this is not indicated because our fever is stable and all the other, vital signs are stable at this time. The final differential would be a pulmonary embolism, which is ICD-10 code I26.99. Key features of this diagnosis would be pleuritic pain, specifically on inspiration. That's between the scapulae, pain on inspiration, or just general pleuritic pain. His SpO2 likely would go down. His respiratory rate would go up. He would likely have a fever, and he would probably feel a bit short of breath. Sorry, you can't see this part, but support or exclusion reasons for Mr. JD. He has no pain with breathing. His respiratory rate, SpO2, temperature, everything is stable, vital signs wise. If we were truly concerned about a pulmonary embolism, we could rule this out with a CT angio. For example, if he was at high risk for developing a clot, if he had AFib or a history of DVTs, we could do a CTA angio to, double check, make sure he didn't have a PE. But he doesn't have those, so we're okay. My working diagnosis here is a viral upper respiratory infection with a mild COPD exacerbation, which is ICD-10 code J06.9. So this diagnosis is evidenced by his low-grade fever of 37.8 degrees Celsius maximum, the clear sputum, a sore throat, and then he also has an absence of the focal chest signs, and his vital signs are stable. So he doesn't have the crackles, he doesn't have, any unstable vital signs. Additionally, specifically for his COPD, he does not have an increased sputum production or a discolored sputum production, and his dyspnea is basically at his baseline. So those are three key factors to remember for COPD exacerbations when they become like more sinister. Red flags for a COPD exacerbation that would definitely require immediate hospitalization for any patient with COPD would be altered mental status, confusion, or sorry, COPD, or, COPD with this exacerbation caused by the viral infection. Altered mental status or confusion, because this could be indicative of a bacterial and like sepsis or something going on, or a hypoxia situation. His inability to tolerate PO, which would be similar reasons. Respiratory rate of over 30 breaths per minute. An oxygen saturation of below 92%. A systolic blood pressure of less than 90 mmHg. Because this would be indicative of sepsis. The respiratory rate being high could be indicative of sepsis, or a hypoxemia situation, hypercapnia, and SpO2 as well. Remember, for our COPDers, we don't have as high of goals for the SpO2 as we do our normal, non-COPDers. So 88 to 92%. If they go below 88, we want to send them in. And if they develop this purulent sputum production in any COPDer, if they have a high fever, send them to the hospital. If they're unable to perform their ADLs and they have inadequate home support, they're not going to be able to take care of themselves. Who knows, if something happens, they might not be able to get themselves the help that they need. If you hear crackles on the respiratory examination, if you assess increased work of breathing, decreased chest expansion, or if you do a chest x-ray outpatient and it shows consolidation or atelectasis, send them, to the hospital right away. Because this can be indicative of something more sinister, and they're very, maybe a little more fragile than our non-COPDers. And then additionally, if you're trying to manage them outpatient, if they're stable enough to be managed outpatient, if they are failing to respond to that treatment within 48 to 72 hours, send them to the hospital. So our plan here for Mr. John Doe is that since he has no fever, that has gone above 38 degrees Celsius, no purulent sputum, his oxygen saturation is above 92%, he has no other severe symptoms, he has good social support at home, he has the wife at home that is available to help him, and he's able to return for a follow-up in 48 hours due to that good social support. He's able to be managed in the outpatient setting. So we're going to manage him with some medications. We're going to increase his salbutamol inhaler, 2 puffs every 4 hours as needed, and continue his maintenance inhalers. We are not going to prescribe any antibiotics since his sputum is not purulent. We are also going to endorse that he follows good supportive care measures with fluid hydration and rest. Follow-up, we instructed JD to return immediately if he develops worsening breathlessness, purulent sputum, confusion, chest pain, or inability to manage at home, with scheduled clinical follow-up in 2 days. And then my questions here are, a 58-year-old with COPD presents with increased dyspnea and purulent green sputum, but without fever. Do they require antibiotics? Second, when initiating oxygen therapy in a COPD patient with suspected pneumonia, what is the initial FiO2 you should use and why? And what parameters must you monitor within 60 minutes? 3, what are the 3 cardinal symptoms of a COPD exacerbation, and what is the appropriate medication course/duration for treatment? 4, if recommending a patient to the ER for COPD exacerbation, what is the first expected task the patient should expect to occur on arrival? And then the 5th one is, what is the first-line bronchodilator therapy for COPD exacerbation in a moderate exacerbation and severe exacerbation?